Hi everyone, hope you're all doing well. And so today we're going to continue our discussion of anticoagulants, and this video is going to focus on the parenteral anticoagulants. So IV, sub-Q, any routes of administration except oral, because we've already talked about the oral anticoagulants in the previous video. So this is going to sort of follow the same format. I'm not going to focus too much on the dose, but I will highlight all the clinical pearls, all the important information about these parenteral anticoagulants. That's including any significant drug-drug interactions, whether or not they require renal or hepatic adjustments, if there's anything special about them, and essentially sort of how they work. So let's start with a brief review first. For our oral anticoagulant options, we have dabigatran, apixaban, rivaroxaban, edoxaban, betrixaban, and warfarin. So all of the details about them and the clinical pearls you can find in the previous video. That is primarily on the oral anticoagulants. And then we have the parenteral options. Those include bivalirudin, argatroban, unfractionated heparin, low molecular weight heparin. The most common one in this category is enoxaparin or Lovenox, and Fonda Paranox. Let's start our discussion of the parenteral anticoagulants with the direct thrombin inhibitors. So remember, the only oral direct thrombin inhibitor that we have available is dabigatran or Pradaxa. And then we have parenteral options. Those include bivalirudin and argatroban. Bivalirudin. So this anticoagulant is dosed with a bolus first, which is 0.75 milligrams per kilo. And then it is followed by a continuous infusion of 1.75 milligrams per kilo per hour. And this medication is heavily renally excreted. So if your patient does have renal failure or they are in acute renal injury, then the bolus is usually kept the same, but the infusion rate is lowered. And you can consult any of the package insert or any of the medical databases to figure out how much if the dose is lowered based on the degree of the renal dysfunction. And the effect of the extent of anticoagulation is monitored with activated clotting time, ACT, or activated partial thromboplastin time, otherwise known as APTT. The other parenteral direct thrombin inhibitor that we have is argatroban, and this is actually what we have on our formulary. We don't have bivalirudin, and just like bivalirudin, argatroban is also given via continuous infusion. The dose is weight-based, and depending on the indication, you may or may not need a bolus. So this one is primarily hepatically metabolized, and so dosing adjustment is recommended in patients who have hepatic impairment. However, in patients who have renal impairment, no dosage adjustment is required. This is the effect of anticoagulation with argatroban is monitored with APTT. And another very important fact actually to know about argatroban is that it does prolong PT-INR. So typically a higher INR, let's say 3.5 to 4.5, is targeted during the overlap time. And if you were to transition to warfarin, and then INR is repeated once argatroban is discontinued to make sure that the patient is within the actual INR goal. So this is really only important if you're going to start the patient on argatroban with eventually transitioning them to warfarin, because as you know, INR is what we use to monitor the anticoagulant effect of warfarin. If you were going to transition the patient to a DOAC or any of the DOACs, then this won't be a problem. You don't even have to worry about that. Another class of anticoagulants that we have is the factor 10A inhibitors. And they're the ones that bind to factor 10A and prevent thrombin generation, which then prevents the escalation of the clotting cascade. And so these we actually only have in oral formulation. These are the well-known DOACs, rivaroxaban, apixaban, edoxaban, and betrixaban. But there are actually no parenteral agents that are currently in clinical use. All right, so the next major category of parenteral anticoagulants that we have is the heparins. And there are sort of three subcategories under that. There is the unfractionated heparin, or UFH, or if we just simply say heparin, we mean it's the unfractionated heparin. The other one is low molecular weight heparin, LMWH. The most common heparin that is used in this category is enoxaparin or Lovenox. There's also dalteparin that is mostly I've seen it used in clinical studies, but there may be some institutions that use that. And then the third subcategory is Fonda Paranox. So how do these heparins work? Heparins actually act indirectly by binding to antithrombin rather than by binding directly to any of the coagulation factors. Binding of heparin to antithrombin actually induces a conformational change in the antithrombin, which then converts it from a slow to a rapid inactivator of coagulation factors. For example, thrombin, the factor 10, the 2A, and then the factor 10A. So that's essentially how they act. So first up, let's talk about the unfractionated heparin. It is a linear polysaccharide that belongs to the glycosaminoglycan family. And all mammals actually produce heparin, and heparin-binding proteins have anticoagulant and anti-inflammatory properties, among others. This is not completely understood. However, the unfractionated heparin that we use clinically is actually a mixture of different length polysaccharides. These have a mean size of approximately 45 saccharide units, could be a little bit more or less, and this then has a mean molecular weight of approximately 15,000 Daltons. Clinically, the unfractionated heparin that we use is isolated from porcine or bovine intestines, so pig or cow, and it is metabolized by the reticuloendothelial system and the liver, and then excreted in the urine. It actually does not require any dosage adjustments in hepatic or renal dysfunction. And this is because you can actually adjust the dose based on APTT or factor 10A, whichever one you utilize for monitoring. In our institution, we actually use factor 10A based monitoring. And so this is a continuous IV infusion that's given with or without a bolus. And that is based on indication as well as patient-specific factors. And the dose is just then adjusted based on APTT or anti-10A activity. In our institution, we have the anti-10A based protocol. We get a level after 6 hours of initiation or any dosage changes. And then once you have consistently 2 anti-10A levels within the target range, it can go a little bit longer. So you always have to consult with your institution-specific protocols for monitoring and dosage adjustment. In terms of laboratory testing, we should actually be getting a baseline CBC to obtain H&H and platelet count. And this should be repeated at least every 2 to 3 days while the patient is on IV or sub-Q heparin. So let me backtrack a little bit. For therapeutic dosing, it is continuous IV infusion, but for prophylactic dosing, so for using usage in medical patients to prevent VTE. This is actually a sub-Q, and that does not really require a lot of monitoring. It does not require any monitoring with APTT or anti-10A, but you should still be getting a CBC to look at patients' H&H and platelets because of the risk of HIT and the potential risk of bleeding. The baseline coagulation studies should also be obtained, so that should include a PT and APTT to verify that the patient does not have an underlying coagulopathy. And then the APTT is repeated every 6 hours till therapeutic, and then the frequency is extended based on protocols, as I mentioned before. We should also be getting baseline liver function tests, as heparins can cause elevation of transaminases. However, this is usually not of clinical importance. So I also wanted to do a little bit of a comparison and look at the advantages and potential limitations of unfractionated heparin as compared to other parenteral anticoagulants. And I'll do the same with the low molecular weight heparin and the Fonda Paranox. So in terms of advantages, the best advantage that IV unfractionated heparin has is that it has a very rapid onset and offset of action. So it's really good because it starts working right away. And then if you need to discontinue it, it's very easy. You just shut it off, and within a matter of seconds to minutes, the anticoagulation effect is gone. So this is really good for any emergent surgical procedures or if the patient starts to bleed. Another advantage is that you can monitor the anticoagulant effect and dose adjust based on APTT or anti-10A activity. This is really good because if you have patients with renal or hepatic dysfunctions or any sort of issues, you can make sure that the patient remains within the therapeutic range, and you have a very specific way of monitoring it. Another advantage is that it can be used in renal failure. And this is a huge advantage because a lot of times when you have patients in the hospital, if they're post-surgical patients or if they are there for any medical reasons, they may have sepsis as well, and that affects the kidneys and other organs. So if you have something like that, that eliminates the need for dosage adjustment in those in patients with renal failure. That's a huge advantage. Another major advantage is that you actually have a reversal agent for this, and that's protamine sulfate. So you can reliably reverse the anticoagulant effect with protamine sulfate, although it's usually not needed, as I mentioned. IV unfractionated heparin has a very quick offset, so unless you have a life-threatening bleed, you probably won't be using it. So let's talk about the limitations now. It is given as a continuous IV infusion, so that is definitely a limitation. You have to have an IV line on the patient at all times and make sure that it works well. So another one is that the dose-response relationship is actually highly variable. That is why you do require the frequent lab testing, and that requires frequent blood draws, which is usually not very comfortable to the patient. And that's another reason, actually, you'll have patients on IV unfractionated heparin usually for a very short amount of time or as limited time as possible, and they will usually be transitioned to something else that the patient is going to be on long-term, whether that's oral or even something like enoxaparin. Another limitation of unfractionated heparin is that usually achieving and maintaining therapeutic levels is challenging, and it has historically been more challenging with APTT monitoring. With anti-10A monitoring, actually, it's been a little bit more reliable, but still it's been an issue. Sometimes you have patients who've been therapeutic and all of a sudden they either go supra or subtherapeutic and you don't quite know why, and you just still have to continue monitoring and adjusting the dose with that. And another big reason, actually, that is a potential limitation is the Hyper-Induce Thrombocytopenia, otherwise known as HIT. And that is a rare complication, but it can be a fatal one. And this is why the platelets need to be monitored frequently. Patients could also have skin reactions, and it is also implicated with osteoporosis with long-term use. The second subcategory under heparins is the low molecular weight heparin. So low molecular weight heparins are actually derived via enzymatic or chemical depolymerization of unfractionated heparin. So it is actually smaller than unfractionated heparins. Its mean length is approximately 15 saccharide units, and the mean molecular weight is approximately 4,000 to 5,000 daltons. It is metabolized by the liver and excreted by the kidneys. About 10 to 40% of it is renally cleared, and therefore renal dosage adjustment is required for creatinine clearance less than 30 milliliters per minute. You start to get worried when the creatinine clearance is between 30 to 50 as well, but definitely dose needs to be reduced when it's below 30. The dose for a lot of the indications is weight-based, and the dose for some indications, such as prophylaxis for hospitalized patients or orthopedic patients post-surgery, is actually fixed dose. It's given sub-Q in both instances, whether you're using it therapeutically or prophylactically, but the dose is different, either fixed dose for prophylaxis or weight-based dose, milligram per kilogram for therapeutic anticoagulation. And it is administered sub-Q, so that's very much less complicated than unfractionated heparin. And it's either given every 12 hours or every 24 hours based on indication as well as the renal adjustment. In terms of laboratory testing, it's very similar to unfractionated heparin. You definitely still need a baseline CBC as well as periodic CBC. So we use that to look at their H&H to make sure there are not any major drops in H&H indicating some sort of a bleed. We also look at the platelet count to make sure that we don't have any reason to worry about HIT. And this can be extended if it's being used outpatient. They may not get a CBC every 2 to 3 days, but certainly should be monitored frequently. We still get the baseline coagulation studies, including PT and ABTT, to verify the patient does not have an underlying coagulopathy. We also obtain, in this case, baseline serum creatinine to assess the renal function, and then as needed thereafter if there is suspicion of renal function deterioration. And we also have to obtain the baseline liver function tests. And as mentioned before, heparins can cause elevation of transaminases, so you kind of want to monitor that periodically as well. So unlike unfractionated heparin, low molecular weight heparins do not require anti-10A or APTT monitoring. It has not been correlated with clinical endpoints, so it's not as relevant as as when we use it for unfractionated heparin. However, there are some instances where you might want to use it. In some instances where the patients or their particular PK/PD factors may not be consistent with general public. So these could be patients who are obese or have renal failure, are pregnant, they're having excessive bleeding, children and neonates. These specific populations, it's usually good to get a anti-10A level to really make sure that you're not over or underdosing these patients, because their pharmacokinetic and pharmacodynamic factors could be a little bit different. And so the way the low molecular weight heparins are acting in these patients could be a little bit different. And so if you were to do that, then the anti-10A level is typically measured 4 hours after the fourth dose. This is when it reaches steady state. And then based on the level itself, you would figure out how much the dose needs to be increased or decreased, if at all. All right, so let's briefly talk about the advantages and limitations of the low molecular weight heparins. One of the major advantage is better correlation between dose and anticoagulant effect. This is why we can have a fixed dose regimen without lab monitoring. So by fixed dose, I mean it's still a weight-based dosing for therapeutic dosing, so milligram per kilogram, but we have specific milligram per kilogram dosing. So 1 mg per kg. If you're going Q12 dosing, you could even do 1.5 mg per kg for Q24 dosing, let's say for a treatment of VTE. So it's a very fixed weight-based dosing as opposed to adjusting the rate or whatnot based on the APTT or NT10A monitoring that we do with unfractionated heparin. So that's a really, really good advantage for this. And for most patients, we don't even have to get any of the anti-10A levels. It does have a longer duration of anticoagulant effect, so that allows for the once daily or twice daily dosing, and that also allows for it to be administered outpatient. A lot of our cancer patients are on low molecular weight heparins. There wasn't a lot of data on the DOACs before. Now there is some, but historically enoxaparin has been preferred in those patients, so they can continue taking it outside of the hospital, whereas for IV unfractionated heparin, that needs to be given in a medical institutional type of setting. You also have a lower risk of HIT with the low molecular weight heparins, as well as a lower incidence of osteoporosis. Now, even though they seem to be better than the unfractionated heparins, they do still have some limitations. They're still slightly a delayed onset, so about 20 to 30 minutes after subQ administration, as opposed to instantaneous effect with unfractionated heparin. This could be critical for patients maybe who have massive PE or sort of any indications where they need to be therapeutic literally right away. It does have a longer duration of action, which works for its, advantage for the most part, but it can also be a limitation because then if somebody were to bleed or if they needed any emergent procedure, it's difficult to you have to either wait or use a reversal agent to get back to the normal hemostasis. And the other problem that goes along with that is that it's actually less easily inactivated by protamine sulfate. So protamine sulfate is still the reversal agent that we use for it, but it's not as reliable. The response is not as reliable. And so that tends to become an issue. And another limitation is that it does have a prolonged half-life in patients with renal failure. So you have to monitor that very, very, very closely. Monitor those patients closely, and those would be the ones that we actually would be getting an anti-10A level and adjusting if needed. Alrighty, last but not the least, Fonda Paranox, which is our third type of heparin in this category. And this is actually a synthetic pentasaccharide. It contains 5 saccharide units and has an approximate molecular weight of 1,700 daltons. So it is derived from the active unit of heparins, but it's synthetic. So the structure looks different from the unfractionated heparin or low molecular weight heparin structures in general. The majority of the dose is cleared by the kidneys and excreted unchanged in the urine. So that does require renal dosage adjustment, and it is actually not recommended to be used in patients with creatinine clearance less than 30 milliliters per minute. The metabolism is not affected by hepatic failure, so you don't need any dosage adjustments in those patients. However, those patients may be at an increased risk of bleeding because they have a lot of changes in their hemostasis. The liver is involved in a lot of in maintaining, a lot of these coagulation factors and whatnot. So that might be just an inherent risk in those patients. But the drug itself, Fonda Paranox, does not increase any risk of bleeding. The dosing is actually, it's subQ and fixed or weight-based dosing. Also does not require any kind of monitoring. And in the setting of an acute MI, actually can be used as IV as well. But for the most part, for most of the the indications, it's going to be given sub-Q. In terms of laboratory testing, you still want to get baseline and periodic CBC to look at the patient's H&H and to make sure that there are no major drops that indicate bleeding, but we don't need to monitor the CBC as frequently because we're not looking at platelets in this case. And the reason is that actually there's no significant risk of HIT with Fonda Paranox. It's actually one of the treatments that's used for it. We also should be getting a baseline serum creatinine and as well as needed thereafter, especially if there is a suspicion of renal function deterioration. So in terms of advantages, it certainly has an advantage of a longer half-life, which allows for once daily dosing. That works in a lot of patients' favor because ultimately it is an injection that they need to give to themselves, or somebody will have to do it for them. And if they have to poke themselves only once rather than twice, that's definitely a positive for the patients. And as I mentioned before, Fonda Paranox actually has negligible HIT risk. It has not been associated with it, and it's often used off-label in the treatment of HIT if we do suspect that. Another advantage is that it does not require any type of monitoring. Its effect is very reliable. And so it's similar to low molecular weight heparin, but even more reliable, that we don't actually do any kind of monitoring for the most part. In terms of limitations, there are a couple. It is very, very expensive. So many smaller institutions may not even have it on formulary. We don't technically have it on our formulary, but we usually do keep some of it in cases where we might need it. And it also does not have any specific reversal agent. So given that it has a long half-life but doesn't have any specific reversal agent, it kind of makes you worried what you would do if somebody were to bleed. Alrighty, so that sort of wraps up our discussion on the parenteral anticoagulants, and I hope that between this video and the previous one on oral anticoagulants, that was a good review and information on the different kinds of anticoagulants that we use clinically. And my plan is to do the next video on HIT, or Hyper-Induce Thrombocytopenia. As I'd mentioned, this is not something that we see commonly. It's actually a very rare complication, but when it happens, it can be fatal. And for most of the institutions, in fact, all of them, they will have some sort of protocols on how often to monitor platelets and what to do when you do suspect HIT. So that's a good discussion to have, just a good way of reminding ourselves why we do that. And then if you have any questions or any suggestions for any of the topics, and please let me know in the comment section, and I'll be happy to do a little discussion on those topics as well. Well, I hope you all take care of yourselves and stay safe.